In health education, again, we're emphasized at the benefit of the medicine for the patient, but yet when we get into practice and we see patients routinely and we prescribe to them, what we often find is the risk side of the equation becomes more pronounced. And we have to balance that in terms of safety for patients. So whether you're practicing in a clinic or whether you're practicing in an institution, what you'll see is adverse events lead to tremendous healthcare utilization and not adherence of medicines. So unless you as a provider are asking about the risk, asking about the adverse events, monitoring for those, they often go undetected or unnoticed and could lead to poor outcomes. So in the case of antidepressant therapy, commonly antidepressant therapy is started and initiated and followed up and monitored in the clinic office. Okay? We often prescribe these medicines. We prescribe them in context of additional supportive psychotherapy, but the medicine becomes a mainstay of therapy for the prescriber. And what we find is that oftentimes these drugs aren't well tolerated and they have a lot of risk. And patients go on and off these medicines over time. And they present to us with anxiety, insomnia, agitation, irritability. And then the doctor has a difficult challenge. Is this the underlying neuropsychiatric illness, or is this actually a side effect of the drug? And what we found is that a lot of times going on and off medicines creates what we call an adverse drug withdrawal syndrome that presents as another symptom. And then you, as a prescriber, need to be aware whether that symptom should be treated or it's actually associated with the drug. And so one of the things you as a clinician should be tuning into, and a prescriber, is could this be an adverse drug withdrawal reaction from going on and off medicines? Another example would be the use of bisphosphonates for osteoporosis and osteopenia. These drugs were heavily marketed as agents that are used to treat osteoporotic fractures. But yet over time, what we learned is that they could actually increase the incidence of long bone fractures as the evidence evolved over time. And so now as a clinician, you were once taught how to use that medicine and prescribe that medicine, and you've had to rethink that and how you educate your patients and utilize those medicines for shorter periods and only for secondary prevention.